Are you starting FY1 in August? This is a list of 10 mistakes that are made by doctors on the wards when they first start. My name is Harrison. I've worked for 4 years as a doctor, and in this time I've seen a lot of FY1 doctors come and go and consistently make the same mistakes. That's not because they're bad doctors, but it's because everyone is too busy telling you what to do, they forget to tell you what not to do. So, kicking off with number 1. Not asking for help. It's extremely important. I didn't realise just how important it was until really after F1 had finished. And it's a classic thing that no one really tells you about. If you do a ward round and all of a sudden the ward round finishes quite late and you've just got so many jobs to do, just ask others for help. So there were so many times I was doing a rotation and there'd be other people on that rotation or potentially in a different rotation but on the same ward as you. Yeah, they may be busy themselves, but if you're completely overrun and you feel that you're just drowning in jobs, just ask them for help. They might just take a few off your plate, and once a few are off your plate, that jobs list looks a little bit less busy and you can organise your thoughts a little bit better. I think one of the biggest examples of this is so many people in the ward might need bloods, and all of them might be urgent for some reason or another. So you need a troponin from one patient, a D-dump for another because you're worried about a PE, or you need some inflammatory markers for someone else because they're escalating and we want to see if they're continuing to go up or not. Just ask the nurses or ask your colleagues. If someone can just take those things off of your hands and you trust that they're going to get done, that's brilliant, because then you can just focus on other things and you can essentially get 2 things done at once. So just ask for help. It's extremely important. A 30-minute job or something like that can then be done in 5 minutes because you've just split it between the team, and that's all what ward work is. It's just working as a team, working together, and essentially it stops you from leaving 30 minutes to an hour late every single day because you just take that time away and you can actually leave on time. So asking for help is a big one. Number 2 is prescribing too quickly. This is another one. So all of a sudden the nurse will come up to you or the consultant will come up to you and they'll be like, they need this prescribed now. All of a sudden you think it's an emergency. Someone's asked you to do something and you must just get it done straight away. When it comes to prescribing, you've always got to just take a little bit of time just to make sure you're not doing anything that's going to harm the patient. So always check their allergies. A lot of the time, a basic antibiotic that people are going to be given is coamoxiclav or something with penicillin in it. Just check, because a lot of people are allergic to penicillin, and if you prescribe that, you're going to make a bad situation much worse. So just check their allergies very quickly. It will take 2 seconds. Another thing is renal function. There's many drugs that are altered dose-wise and timing-wise depending on what the patient's renal function is. Another one, let's just say antibiotics, just to keep on that. With coamoxiclav, say, normally you'd give it, if you give it IV, you can give it 1.2 grams 3 times a day. If someone's renal function's really poor and their creatinine clearance is less than 30, that dose and timing is going to be adjusted. A lot of the time it can be 0.6, 2 times a day, but your BNF is your best friend there. It will tell you exactly when and where to give the drugs. But there's so many drugs that are adjusted on renal function, so unless you're certain it isn't, I'd just get it checked. Another drug renal function change is enoxaparin, so just VTE prophylaxis. Enoxaparin changes on weight and on renal function, so if someone's renal function is really, really poor, they may not even be able to have enoxaparin. So again, it's just one of those things. Your hospital should have a guideline on it. If not, the BNF will tell you whether or not the patient can have that drug or not. So the third thing is interactions. The luxury of having an online system, if you're prescribing on that, it can tell you the interactions between a lot of drugs. So things like clarithromycin and statins, they should not be prescribed at the same time. There's things that you need to check that if they're prescribed, you need to either suspend one, and if the other drug is extremely important to be given, or you just need to pick another drug. So with antibiotics, there's a lot of antibiotics like clarithromycin that interacts with a lot of other medications, and it can potentially reduce their efficacy or increase their efficacy. So you need to just have a look at that. And potentially, if there is something that really would change for the patient, then it might be a time where you need to choose another antibiotic instead, because that would be better for them. It's just another one of those things you need to look at just to make sure that the drug you're doing for the patient is actually helping them rather than making things worse. So I think the three things mainly to look at when prescribing is allergies, renal function, and interactions. So then there's number 3, staying on the same sort of vibe as prescribing, is prescribing without reviewing the patient. There will be a lot of times on the ward where you'd have just done the ward round, you'll have your list of jobs ready to go, and someone's just going to come up to you and be like, "Doctor, can you prescribe this patient XYZ?" So a lot of the time it can be, "Doctor, can you prescribe this patient fluids?" They may be waiting for an operation, or they may be nil by mouth for whatever reason, and a lot of the time they like to be put on maintenance fluids just to make sure that they don't get dehydrated. You may just think, "Oh, that's an easy job to just get done. I'll just prescribe fluids straight away." You start them on a bag of saline or Hartmann's or whatever the preferred sort of fluid is on the ward you're on, and you do it over however many hours. The issue with this can be if the patient has things like heart failure, or they came in with fluid overload or something like that, they shouldn't really be given fluids as quickly. If it's required at all, they shouldn't be given fluids quickly. So say a patient with heart failure or something like that, and you just do them a bag of IV fluids over 6 to 8 hours or something, that fluid is not going to get processed by the heart well at all, and it's just going to end up in their legs or in their chest, and they're just going to become more out of breath, and it will end up doing more harm than good. So just have a quick look through the patient's past medical history, check why they came in. If they have no past medical history and they came in with something completely unrelated to fluid, then absolutely giving them fluid over just a sort of 6 to 8 hours is absolutely fine if they're young and healthy. If they're a frail, older patient, they have a little bit of a background of heart failure, just do the fluid slower if they are needed. I usually aim for, if they're old and frail with heart failure, 12 hours. If they've got really severe heart failure, maybe talk to the consultant about whether fluids are actually required at all. And if they're not, you can talk to them about what an alternative would be. That's just one example, but prescribing anything without reviewing the patient can be dangerous. You always want to just have a quick look, even if it's just online, about why they came in, what the actual situation with them is at the moment, and just check, is what I'm prescribing for the patient going to help them, or is there any chance it's going to harm them? So number 4 is a pet hate of mine. It's messy documentation and not documenting things at all. There's nothing more annoying about going to do a job for a patient and you take ages doing it. You talk to a family member or something like that, and then you document it, and all of a sudden you speak to the doctor who was looking after them yesterday, and they were like, "Oh no, I did all of that yesterday," but they just didn't write it down. So you had no idea essentially what's happened with the patient the day before. I would strongly recommend, if you're doing anything with a patient, any family discussions, any discussions with other specialties or anything like that, people like the radiology team, like the duty radiologist at the time, if you've vetted a scan, any referrals that you make, just document it in the notes. A lot of the time you can just print off emails if referrals are made, but anything like, say a scan was rejected, your consultant wanted an MRI head for a patient, and the duty radiologist doesn't think is a good idea. If you just write it down in the notes, the doctor the next day will just look at that and understand, oh, that's why the MRI head is not done. If you don't write it down, no one will have any idea, and essentially they're going to do the same thing. They'll call the duty radiologist the day after, and the same thing will happen. You can just save people time if you just write down what you've done. You don't have to write down everything, not like every small little job that you've done, because it's usually quite obvious, but big discussions, things that will change the management for the patient going forward, always just jot it down in the notes. An important one is family discussions, because that's something that is involving people outside of the hospital team. If anything were to happen with that patient and the family potentially put in a complaint about the care that patient had, you can always then look at the patient's notes and look at the documented discussions that the doctor team and the nursing team and everyone has had with the family throughout that patient's stay. It's just an important thing to do and get into a good habit of documenting things regularly. And documenting is no good if the handwriting is just completely awful and no one can read it. I understand everyone's in a rush, and I understand there's a lot of things going on during the day that are probably more important to you than writing things down in the notes. But if you just make your handwriting, it doesn't have to be perfect, if you just make it legible so that other people can read it, then that's perfect. Take a little bit of time, write everything down, and you'll be good to go. So the documenting side of things will be all good. Number 5 is forgetting to prioritize. So you've just done a really busy ward round. You've been given a shed load of jobs by the consultant or the registrar or whoever led the ward round, and you just are panicking essentially. In your head you've just got loads of stuff to do and you don't know where to start. A lot of the time you'll just start working your way through that jobs list from top to bottom, from the first patient you saw to the last patient you saw. Although that can be okay sometimes, a lot of the time it's not the most ideal way to go about doing things, because sometimes, say the last patient you saw that day, they may have been the most unwell, and they may be the patient that the jobs need to be done for first, especially if it comes to things like vetting scans, sending referrals off, getting bloods done. If you're investigating something, potentially say a patient had a fall and all of a sudden they're vomiting, their GCS is reduced, and you're like, oh, there's a chance they could have a bleed in the brain. If they're the last patient you saw and you just leave that and do that CT head request and vetting last, that patient's bleed could get worse and worse. I mean, worse things worse, that patient could just could deteriorate rapidly, and a peri-arrest may be needed to be called, or worse. So what you need to do instead is have a quick browse through your jobs list. If anything seems urgent to you, I'd get one of those pens or another coloured pen and circle it in red, and I'd get those done first. So like I say, any scans, any urgent bloods, any urgent referrals, potentially then after that you could get the discharge letters done, just to get the patients out of the hospital and continue that patient flow. And then if there's just any standard run-of-the-mill jobs that you can do, then do those afterwards. But just obviously it depends on the day, but I'd just have a look through your jobs list first, look at the urgent ones, then the routine ones, and then anything that you can just do as and when you need to do it, you can do those jobs last. You'll get pressured by some of the team a lot of the time to try and get discharge letters done first, because everyone's priority in the ward is different. Some people's priorities is to get patients out of the hospital and get new patients into the ward. That isn't your priority. Your priority is to always treat the sick people first. Make sure everything is done that is needed to be done for the unwell people and any urgent investigations. And once that's done, then yeah, you can work with the rest of the team and do the discharge letters. But always treat the sick first and make sure everyone is stable before you carry on with the sort of paperwork side of things. So number 6 is a very common mistake that I see a lot of FY1s make, and that's not writing jobs down. It can really hurt your day. I mean, if you have a really busy ward round, again, it also always seems to stem from a really busy ward round, but it is true. If you have a busy ward round and you're just barked at loads of jobs, there's no way you're going to remember all of them. If you don't write them down, even if it's messy and you just have just notes at this point, just to make sure you get the jobs down and so you know what you're going to do later on in the day, get them on paper, because in a busy, stressful situation, your mind is just going to forget things. And it's going back to point 5 just before. If you don't have all of the jobs down, you're not going to know which are the important jobs that you're going to need to do first. So like I say, during a busy ward round, it's not important that you get a pristine jobs list in front of you so you know exactly what you need to do when and where. But if you get the jobs on paper, after the ward round's done, you can, if you bang out a few of the jobs, you can just then make a sort of a shorter, neater jobs list, so you just have an idea of what you need to do and when. As the day goes on, the jobs list might fill up a little bit again, it might get a little bit more messy. Always feel free to just get another sheet of paper and just rewrite the outstanding jobs down. I always think a pen with 4 colours in it, or just another type of pen. So if you, a lot of the time you're just writing in black, because that's what the notes are made. You need to write in black in the notes. But if you have one of those pens that has green, blue and red on it as well, you can circle, say, the urgent jobs in red. You can use the green and the blue to just highlight specific jobs that you want to do next or something like that, and it can just help divide up the jobs list, making it easier. But you're not even going to have that jobs list if you don't write things down. So always make sure you get things on paper. If a nurse comes up to you during the day and asks you to do something, write it on the paper. If you don't, do it straight away. The same if a consultant or another doctor comes up to you during the day, write it down. That way you're not going to miss anything, and when it comes to the next day and someone asks, was this done, you'll always be able to say yes, because you wrote it down and you got it done and you were organised. So number 7 is a non-medical thing, but it's extremely important nonetheless. Skipping breaks, skipping food and skipping water. It's just something you simply can't do. You might be able to get away with, not having food at 12, 1 o'clock and then maybe having it a little bit later. But if you just consistently miss meals, you don't drink water throughout the day, you're just surviving essentially off coffee, you're just going to get headaches, you're going to feel exhausted, and essentially you're just going to burn out extremely quickly. You're entitled to your break. Make sure around lunchtime you take yourself away from the ward. You have 30 minutes just to have some food, get some water in you, and you just essentially do something other than medicine for a little bit. I understand this isn't always possible at the same time, because someone might be extremely unwell at this point and you might be dealing with an emergency. That's absolutely fine. That will come first. But once that's done and everyone's safe and all patients are okay, hand over to another doctor who's going to be on the ward. Ask them to simply just look out for your patients for the 30 minutes while you're gone, have your break, and then come back and continue. You'll feel so much better. You'll be able to get through every day sort of more confidently, happier, and you won't burn out as quickly. This is especially important when you're on call. Those 12.5-hour shifts, or however long the shifts are, you get 2 breaks at that point. The breaks differ depending on how long the shift is or what shift it is. A day shift, you get a 30-minute break throughout the day. If you have a night shift, I believe it's an hour and a half, but I could be wrong, but you can split that up into multiple breaks. But just make sure you take them. It will really help you going forward. So then, staying on the theme of burnout, number 8 is staying late instead of handing over appropriately. If your hours during the day you're meant to work at 8 to 4 or 8 to 5, 8 to 6, whatever it may be, if you're consistently staying an hour late or something like that, you're just going to overwork yourself. The reason the shift patterns are how they are, and when you have days off how they are, is because you've worked a certain number of hours and then you'll need a break after that. If you're consistently putting in more hours than the allotted hours you're meant to work, you're going to burn out. There's no question about it. I've seen so many people do it. I've done it. Once your shift is finished, just hand over. Every single job I've done, there's been some way in which you can hand over to a late doctor. There's usually doctors that cover the wards after the day shifts are done. If you're doing a late shift, you can hand over to the night team. And if you're doing the night shift, you can hand over to the day team again. There's always going to be a doctor covering the hospital, and you can just hand over to them. They can look after the jobs. And certain jobs don't even need to be handed over. If you're staying late to do admin tasks that essentially won't change the patient's safety, won't change the patient's health, and they're not going to change the patient going home or anything like that, just do it the next day. And if it's a different doctor on the day after, don't feel bad about it. Everyone's doing the same job. They can do it the next day instead. You're entitled to go home when your shift finishes. If you do have to stay late for a specific reason, a lot of the time this is when a patient deteriorates suddenly towards the end of the shift. That's fine, that happens. You look after the patient, you get a good management plan in place, and then once that's done, you hand over. Say you're meant to finish at 4 and an emergency happens and you end up finishing at 5. Usually an emergency has happened and the people are aware of this already, but if they're not, hand over to another doctor, make them aware of it, and don't forget, if you do have to stay late, you exemption report. You put in the amount of hours you've worked overtime, and you should get some sort of reimbursement for that, whether it be time in lieu or you get paid the extra hour. So don't stay late, but if you have to, be safe about it and don't burn out. Number 9 is quite a big one, and sadly you see it quite a lot, and it's ignoring nurse concerns. A common thing that happens when certain people start FY1 is they think they're God's gift to the hospital. They think they've done medical school, they might have done really well in medical school, and they just think they know everything. This usually unfortunately leads to them getting humbled quite quickly, and usually in quite an embarrassing way. And a typical way this usually happens is because someone would think they know more than colleagues, particularly nurse colleagues. So if the nursing team comes up to you and they have concerns about a patient, don't just disregard their concerns because you think that they know less than you do. Hear them out, ask them why they have their concerns. Feel free to question them, but don't just disregard it. Usually you should review the patient, make sure that everything is okay, and if they're not, you talk to the nurse about why they had the concerns, what's going on essentially. But it doesn't just happen with nurses as well. Unfortunately, some doctors think they're better than other doctors in the hospital and they don't listen to them. You just have to know you're brand new to the hospital. Take advice from everyone. No one's there to put you down or anything like that. Everyone's there to help you. Obviously, as time goes on, you are going to get more confident, you are going to know more, and that's absolutely fine. But at the beginning, just make sure you understand that everyone there is most likely going to have more experience than yourself. They may not have more knowledge, that's not the case, but they are going to have more experience, and experience pays in hospital because you've just seen things before. So listen to everyone and just work in the team with every member of the team, whether that be the nursing team, the physios, the occupational therapists, the ward clerks, everyone. Listen to everyone and everything will go okay. So number 10 is kind of the opposite of number 9. Rather than thinking you're better than other people, it's comparing yourself to every other FY1, every other doctor in the hospital. Imposter syndrome is a very real thing. I think everyone gets it at one point or another. We still get it now. Registrars get it. Consultants get it when they become consultants for the first time. Everyone gets it throughout their career. Because ultimately there's always that doubt that you don't think you're ready, but you are. You've passed your exams. You've got into medical school initially. You've passed those exams. You've got into the hospital. You're now a doctor and you can do the job. Everyone knows the knowledge at the beginning. I think what makes working in a hospital easier is obviously you pick up knowledge as you go, but it's just being in the hospital and getting more experience and being able to do the jobs more confidently and more calmly. That will only come with time. Don't worry too much at the beginning if things are difficult. They probably are going to be difficult at the beginning, but as time goes on, you'll be fine. I struggled a lot at the beginning. I did my first 4-month rotation not in the hospital. So my first 4-month rotation, my second rotation, was the first one I actually did in the hospital. So I felt 4 months behind everyone else. I had extreme imposter syndrome. I really didn't think I could do it. But as you quickly learn, the learning curve that everyone bangs on about is extremely true. You learn quickly. Within a few weeks to a month, I was up to speed and feeling absolutely okay. So just cut yourself some slack, give yourself some time, and everything will be okay. So those are 10 of the most common mistakes I've seen FY1s make on the wards. The good news is that every single one of them is avoidable once you're aware of them. If you're starting FY1 soon, remember, you don't need to know everything. Focus on being safe, stay organised, and ask for help when you need it. If you found this video helpful, make sure to like and subscribe for more FY1 survival tips, on-call guides and practical ward advice. And if you want quick reference cheat sheets covering sort of common ward emergencies and on-call scenarios, then check out the link in the bio to see the on-call companion is a PDF sheet I made. But thank you for watching, and I'll see you in the next one.